Everyone, today we would start the topic of operations of the upper limb. So, first topic is the puncture of the shoulder joint. In the puncture of the shoulder joint, it is done because inflammation with exudation. Contraindication is hemarthrosis. And what is the procedure? Patient lies on the unaffected side or he sits. There are three approaches. First is anterior approach, lateral approach, and posterior approach. In the anterior approach, we should palpate 3 cm distally to the acromial end of the clavicle. Okay. Along the coracoid process of the scapula, a needle is inserted 3 to 4 cm deep between the head of the humerus and coracoid process. This is anterior approach. What is lateral approach? A needle from the acromion of the scapula along the frontal plane inferior through the deltoid muscle. This is the lateral approach. And posterior approach is the needle inserted from the acromion between the posterior margin of the deltoid muscle and inferior margin of the supraspinatus muscle. Inferiorly, perpendicular and 4 to 5 centimeters in depth from the point of insertion. Now these three are the approaches which we can puncture the shoulder joint. See, in this picture, posterior puncture of the shoulder joint is in this. Anterior and lateral puncture of the shoulder joint is the second one, and general view of puncture is the all three general view. So through this picture you can memorize, imagine, and you can keep remember the procedure. Now second is arthrotomy of the shoulder joint. Okay, why should we do this? Drainage of the spurative arthritis. Spurative, we should do the drainage of the pus, and for arthritis also it is used. There are two approaches of this procedure. First is anterior and posterior. In anteriorly, first the patient should lie in the supine position with affected limb abducted. Okay. Then what should we do? Dissection of the skin, subcutaneous tissue and fascia from distal to anterior edge of the acromion. Now, the tendon of the bicep brachii, which is a long head, is accessed by dissecting the fibers of the deltoid muscle. The fibrous sheath covering the tendon and synovial sheath opened with the grooved probe. Don't forget. In operations, you should not mug up everything, okay? You should remember the main point. Patient position, then we should do dissection, then what are the muscles coming, and the instruments. If we remember it sequentially, only the main points, you would remember the complete operation. But if you try to mug up the whole procedure, it won't, because there are many operations, many procedure, many approaches. So this is the way, and you should do multiple revision. By through this only you would I think so remember all these things. Tendon of the bicep brachii is retracted, and lateral tendon is dissected with scalpel and pulled to plica of the capsule. Now the drainage of the pus is done, but it's not enough. So posterior arthrotomy is done simultaneously. So posterior arthrotomy is also needed. So what should we do? Patient lies on the unaffected area. Dressing forceps through anterior dissection, protrusion of the tissue on the posterior surface of the shoulder joint. Then we should dissect skin, subcutaneous tissue, superficial fascia from superior to inferior. Now deltoid muscle is separated with fibers and supraspinatus, infraspinatus, teres minor muscles which are opened transversely. Capsules of the shoulder joint is opened by tip of the dressing forceps. The dressing forceps is used to hold the drainage tube, and it is stretched to the shoulder joint. Necessary to put the sterile gauze with antibiotic solution anterior dissection for few days. Okay. This was about arthrotomy of the shoulder joint. Now next is Langenbeck's and Challin's resection of the shoulder joint. There are two procedures. One is Langenbeck's and another is Chaclin. Langenbeck, what he said: incision along the deltopectoral groove, 6 to 8 cm in length. Deltoid and pectoral muscle is retracted to expose the shoulder joint. Incision is made of the capsule to resect the articular surface. Ankylosis may occur after this operation. And what does Jacqueline said? Procedure similar to the Langenbeck, but difference is incision is 1 centimeter lateral to the deltopectoral groove. Here we would do incision along the deltopectoral groove, which is 6 to 8 centimeter in length. But here we should do incision 1 centimeter lateral to the deltopectoral groove with the dissection of the sheath of the deltoid muscle. Now the procedure is, patient is in the supine position. Skin, subcutaneous tissue and fascia is dissected on sulcus deltopectoralis is performed 10 to 12 centimeter distal to the coracoid process. Then cephalic vein is exposed and pulled to the lateral side. Fascia on the space between the deltoid and pectoral muscle is dissected by the grooved probe. Hand is adducted. Ligament and sheath of the tendon of the long head of the bicep brachii muscles are dissected. Then the tendon sheath is moved to the medial side. Capsule of the shoulder joint is opened along the tendon and dissected from the anatomical neck of the humerus. Shoulder is rotated medially to expose the greater tubercle of the humerus. It is stretched with supraspinatus, infraspinatus and teres minor muscle. Shoulder is abducted to expose the lesser tubercle of the humerus. Then head of the humerus is sawn with a Giel's chain saw. Sharp edge is removed by the scalpel. Now the cut part of the humerus is sewn with glenoid cavity of the scapula and shoulder joint is fixed by the plaster of Paris. Now this was about the Langenbeck and Jacqueline's resection of the shoulder joint. Now next is puncture of the elbow joint. Okay, what should we do in this? Patient should sit or lie on the unaffected side, mostly sit. Posterior and posterolateral approaches are there. In posterior approach, patient should flex the elbow joint at 135 degree and needle inserted over the olecranon at the anterior direction. In the posterior lateral, needle inserted downward from the lateral epicondyle of the humerus and to the lateral direction from the olecranon and penetrate the elbow joint directly above the head of the radius. Okay, next is Voino-Yasenkitsky arthrotomy of the elbow joint. Now, according to this scientist, or I don't know who was he, so according to him, in purulent arthritis of elbow joint, we should do 3 longitudinal, okay? 3 longitudinal dissections are there, which are 2 anteriorly and 1 posterior laterally. Now, first longitudinal dissection made through all the layers before reaching the elbow joint 1 centimeter to the anterior direction from to the medial epicondyle of the humerus. Second longitudinal dissection should be through all layers till the capsule of the elbow. Posterior dissection layer by layer longitudinally to the lateral direction from olecranon of the ulna, which is close to the lateral epicondyle of the humerus. Then drainage tube is inserted transversely to posterior medial compartment of the elbow joint. Next is puncture of the wrist joint. A needle is inserted from dorsal radial margin to middle point, which connect to the styloid process and to metacarpal bone. Now next is general principle and stages of the amputation and disarticulation. Amputation is removal of the distal part of extremity by length, and disarticulation is removal of the distal part of the extremity at the level of joint. First is indication. There are 2, absolute and relative. In absolute, it is crushing of the tissue, massive gangrene, 3rd and 4th degree of burnt or frozen tissue. And relative is chronic infection, osteomyelitis, tuberculosis, septic arthritis, malignant tumor, which is osteosarcoma, trophic ulcer, congenital acquired limb deformity, chronic vascular insufficiency of the extremities. Now, classification of amputation is clinical classification by Burdenko according to the time. Now, first is early amputation. In early amputation, the primary or urgent amputation, first 24 hours done before developing inflammation to save the patient's life, which is done at, for example, traumatic amputation of limb with profuse bleeding. Second is Third is secondary emergency amputation. First day to seventh day amputation of lower limb due to diabetic angiopathy. Fourth is late elective amputation. There is no specific time. Patient prepared thoroughly with complete examination. For example, chronic osteomyelitis, congenital malformation of the bone. Fifth is repeated amputation or reamputation. Post-operative complication or formation of defective stump. Now next is anatomical classification according to the shape of the cut tissue. First is guillotine amputation. Most primitive type of amputation. All tissues are divided at the same level and bone end left exposed or cut surface. For example, gas gangrene. Second is circular amputation. Soft tissue and bone are cut at right angle to the axis of the limb, and skin and muscles are divided circularly and lowered than the bone so that provide covering to the bone stump. Third stage is cutting the skin and soft tissue and cut bone at the level of contracted and retracted tissue. Cutting of muscle at the level of the contracted and retracted skin and fascia. Retraction of the muscle and cutting of the bone. Cutting deep muscle at the level of the contracted and retracted superficial muscle. Retraction of them and cutting of the bone. Third is amputation by using flaps. Most widely used, soft tissue is cut in first 1 and 2 flap or more than 2 flap. Amputation using an elliptical incision. Skin is cut at an angle to the axis of the limb. Fifth is amputation using racket incision. Straight incision proximal to the circular elliptical incision, used especially for the disarticulation of the metacarpal metatarsophalangeal joint or shoulder or hip. According to the tissue used to cover the bone saw line. There are different methods. Fasciocutaneoplastic method. Here bone saw line is covered by skin, subcutaneous fatty tissue and fascia. Fascicoplastic method, bone saw line is covered by fascia. The fascia is transformed into bone. Next is tendinoplastic method. Tendinoplastic method, bone saw line is covered with tendon of muscles. For example, amputation of thigh with covering of bone saw line by quadricep tendon. Myoplastic method is antagonist muscles are stitched to the bone saw line. Periosteoplastic method is periosteum is included in the fasciocutaneous flap. Osteoplastic method is bone saw line is covered by bone with periosteum. Next is general principle of amputation with and disarticulation. It is conserve as much tissue as possible. Removal of bone should be minimized. Should not be any tension when stitching the flap. Scar should be dorsal. Palmar flap with long to retain tactile sensation. In middle and distal phalanges, amputation through the phalanx rather than to the disarticulated the joint. Done to conserve attachment of tendons of flexor and extensor muscles of phalanges. Flexor and extensor tendon should not be stitched across the bone stump because it will limit the finger movement. Now next, metacarpal head should be preserved. Even amputation of the index and little finger is done. For cosmetic purpose, margin of the metacarpal bone should be divided obliquely so that it would be difficult to realize that a finger is missing. Next is stages of amputation and disarticulation. Dissection of the skin, cutting of the soft tissue of the extremities, ligature of the vessels, cutting of the periosteum, cutting of the bone, cutting the nerves to prevent the phantom pain, and stump formation, suturing of the soft tissue above the bone. Now next is estimation of the length of the skin flap for amputation. This is done for forearm and leg. What methods are used is fascicoplastic, myoplastic and osteoplastic. Depend on the layer which include the flap. Length of the flap depends on the level of injured soft tissue. In amputation of lower extremities, posterior stump is covered by anterior long flap. Primary amputation, flap obtained from any surface. If skin is not available, then autoplasty is done. Fascioplastic amputation, upper extremity and bone stump is covered by fascia. Osteoplastic done on lower extremities. Now one flap method, length is equals to 2 pi r, length of a circumference We know this formula. So length is equals to 2 pi, radius is diameter upon 2, which is 3.14, which is approximately 3. So diameter is equals to length of circumference upon 3. For example, if length is 36, then diameter would be 12 centimeter. One flap must be 12 centimeter to cover all the bones. So next is amputation of the arm. According to Pirgov, conical circular method is used. Flap is long posterior flap, long anterior flap. Amputation of arm, middle, lower 1/3. Dissection of the skin, subcutaneous tissue and fascia. Anterior long and posterior short flap is made. Stretched proximally and muscles are dissected with scalpel. Dissection of bicep brachii muscle is done distally. 2% novocaine where anterior to the radial nerve. Muscle is stretched and protected by retractor. Periosteum is dissected around the bone 3 mm longer than the cut edge of the bone and separated with raspberry. Cut the bone. Brachial artery, deep artery of arm and collateral artery of the elbow joint are ligated at the stump. Median nerve, radial nerve, ulnar nerve, musculocutaneous nerve and medial cutaneous nerve is cut off. Stump is sewn layer by layer, fascia by catgut suture and skin by silk suture. Amputation of arm of upper 1/3 by Farabeef. Along the sulcus deltopectoralis, the skin, subcutaneous tissue and fascia is dissected until inferior margin of pectoralis major muscle to separate this muscle from humerus. Coracobrachialis muscle sheath is dissected and brachial artery is ligated. Soft tissue is cut until the bone along the anterior, inferior and posterior margin of deltoid muscle. This muscle is separated from the humerus. The bony muscular flap is stretched proximally. Tendon of teres major muscle dissected. Soft tissue is dissected along the posterior medial surface of the humerus until reach the bone and all soft tissue is retracted by retractor. The periosteum is dissected and retracted distally and humerus is cut 3 to 4 mm distally to edge of cutting periosteum. Median nerve, ulnar nerve, radial nerve, musculocutaneous nerve and cutaneous nerve of the arm and forearm are dissected. Axillary nerve is preserved to innervate the deltoid muscle. Stump is sewn layer by layer, fascia by catgut suture and skin by silk suture. Next is amputation of the forearm. Patient is in the supine position, general anesthesia is given. Amputation of the lower 1/3 of the forearm is done by circular dissection of skin, subcutaneous tissue and fascia is done 4 cm distally to place where the bone is cut. Skin, subcutaneous tissue and fascia is retracted by cuff in conical shape. Medial and lateral part of retracted is dissected. Amputating scalpel separates the muscle from the bone. Flex the wrist and scalpel is held right angle to the bone and the muscle. Wrist extended tendon and flexor muscle is distended. Cut the muscle on dorsal surface of the forearm. Muscle is retracted. Then 2H scalpel is inserted between ulna and radius. Dissected interosseous membrane. Periosteum of radius and ulna stretched distally by raspberry. To dissection of median muscle done until middle length. Soft tissue is retracted. Bone of forearm is sawn 2 to 3 mm distal to the dissected periosteum. All vessels are clamped but are not cut. Wound is sutured layer by layer, fascia by catgut suture, skin by silk suture. A drainage tube around the edge of the wound. Hand is immobilized by plaster of Paris. Next is amputation of upper half of the forearm. Flap of anterior radial and posterior ulnar, skin of 3 to 4 cm anteriorly and 1 to 1.5 cm posteriorly. Skin, subcutaneous tissue and fascia. Anterior region, superficial layer, then deep layer are dissected. Posterior region, all muscles are dissected from superficial to deep layer at once. Bone is sawn 2 to 3 cm distal to the dissected periosteum. All vessels are clamped but nerves are not cut. Wound is sutured layer by layer, fascia catgut suture, skin silk suture, drainage tube around the edge of the wound and hand is immobilized by plaster of Paris. Now next is disarticulation of the phalanges and finger. Scar has has to be on non-working surface. Thumb, index finger, little finger, dorsal and radial surface. Middle and ring finger on dorsal surface. First one is Malgenous disarticulation of the thumb. Dissection of the skin and subcutaneous tissue. Metacarpophalangeal joint on the dorsal surface until interphalangeal fold on the palmar surface, and then dissection on the dorsal surface. Thumb is retracted with a hook on dorsal dissection. Hook on the dorsal. Dissection is exposed metacarpophalangeal joint. Then with the scalpel, palmar surface around the joint capsule at 45 degrees Celsius. Most important is protect the muscles of the thumb and retract it to sesamoid bone, which is on the anterior surface of the joint capsule. Tendon is flexor and extensor, sewn wound and suture. After this operation, function of the hand decreases by 50%. Farabee's disarticulation of the index and little finger. Dissection of the skin subcutaneous tissue on the dorsal surface of the index finger, from lateral surface to the dissection of the radius, and then space between the index and middle finger is dissected. On the palmar surface, transverse dissection on the ulnar edge, metacarpal joint up to dissection on the dorsal surface. Same dissection performed on the little finger, and flap is dissected. Tendon of the extensor dissected distally to the head of the metacarpal bone on the metacarpophalangeal joint, and ligament is dissected by scalpel. After capsule is seen, tendon of the flexor is dissected distally. Arteries are ligated and nerves of the dorsal and palmar branches dissected. Tendon, flexor and extensor is sutured. Head of the metacarpal is preserved. Wound is sutured to cover the head of the metacarpal bone. Next is disarticulation of middle and ring finger by racket form. Racket shaped dissection from dorsal metacarpal bone. A oblique dissection is made at the base of the phalange on the palmar surface. A palmar crease, other side is base of the phalange, longitudinal dissection on the dorsal surface. Flap of skin and subcutaneous tissue is retracted from the base of the phalanx and proximally by a hook. Distal to the head of metacarpal bone, tendons of the extensor is dissected. Joint of the capsule is dissected on dorsal, medial, lateral and palmar surface. Tendon of the flexor and soft tissue is dissected and cleared off. Vessels are then ligated. Nerve is dissected from the proximal part of the head of the metacarpal bone. Then tendon of flexor and extensor at the head of the metacarpal bone are sutured. Wound is also sutured. Next is operations on the vessels, nerves and tendons. Sutures of the arteries. Rules are: suture can be circular or side suture. Stitches hermetically done and strong. Sides must not constrict the vessel. Tunica intima must be connected. Threads must be absent from the vessel in the lumen to prevent thrombosis. Cross section of the vessels after suture must be same as others. Lateral side suture of the arteries. Indications is injury less than 1/3 of the vessel. Vessels are separated from the surrounding tissue and clamped upper and lower part of the injury. After dissection of the edge of the damaged part of the vessel through all the layers transversely, 1.5 to 2 mm silk suture is applied. If bleeding between the sutures, flap from the fascia or veins are sutured. Circular method by Kahl and Morozova. Kahl's circular method. Indication is extensive injury to the vessels. Main trunk of the artery separated. Prevent damage of adventitious layer and branches. Proximal and distal part is clamped. 3 sutures. P-shaped stitched from intima to intima. Needle, then a needle into the vascular lumen, irrigated with isotonic solution, sodium chloride solution. Assistant holds the handle of the forceps and dissect the next suture to the surgeon. Then direct the next suture to the surgeon. Then with the forceps, vessels are stitched. Assistant hold the sutures so it does not get loose. Last stage, suture one edge, tie up the suture and prevent the corrugation. Same method for another two sutures. Before tying up suture, distal clamp is slightly opened. When suture is tied, distal clamp opened completely and bleeding part is whipped off with gauze. Bleeding ceases few minutes if not extra sutures are applied. Morozova's circular method. Difference is to suture used for fixation. Solovian's method, P-shaped suture is applied. Polyansev's method, suture artery with invagination of margin with the help of metallic ring. Gudov's metallic stampling is mechanical suture which resembles stampling method. Operations on the vein. Indication is varicose vein in the lower limb. Conservative method. Elastic stocking and bandages used when varicosities are widespread or diffused and appear to be unrelated to the saphenous system. Sclerotherapy. Injection on sclerotic solution with soap solution, ethanolamine, hypertonic solution, glucose sodium chloride solution, organic compound quinine, urethane. Operative method is elimination of the shunt from the deep venous system. Troyanov-Trendelenburg's operation. This is done to prevent thromboembolism. Incision of 4 to 5 cm distal to the inguinal ligament and parallel to it. Greater saphenous vein, double ligature near where it empties into the femoral vein. Lateral and medial surface of the thigh. Accessory vein is ligated and cut. This operation is cosmetic but not radical. Radical operation is necessary in future. Next is Linton's operation. This is for subfacial ligature of the communicating vein along the entire surface of internal surface of leg. Cockett's operation. Ligate the varicose vein through puncture of the skin. Ligature in around the vein. Ligature in around the vein and then out. Recanalization of the ligated vein is performed later. Removal of superficial varicose vein. Madelung's operation. Long dissection along venous saphenum magnus. Narrates operation, multi-dissection for resection of the vein. Babcock's operation, elimination of the vein by probe, elimination of the circulation and obliteration of the superficial vein. Linser's Sicard's method is multiple injection and sclerosants in small doses. Next is operations on the nerves. Do physical examination with electrical instrument, then choose from these two methods. Neuroraphia, neurolysis. Indication is tumor, trauma, formation of a scar after amputation, compression of the tissue by a scar or puny callus. Neuroraphia. Indication is complete anatomical interruption of a nerve and presence of cicatricial tissue. There are three types. Primary suture. During primary treatment of damaged nerve with wound suturing of the edge, end of the damaged nerve is dissected with scalpel. Fine needle and thin silk suture of 2 to 4 mm from the edge of nerve to epinerium. Nerve is sutured by 2 to 4 stitches. Surgeon and assistant stretch the suture at end by 1 to 2 mm and suture is tied, which is interrupted suture. For example, elbow joint is flexed. Median nerve or radial nerve is sutured on flexor surface. Ulnar nerve is damaged. Suture applied from dorsal surface of the elbow joint to anterior surface. After suturing the nerve, fixation and immobilization of extremities are done with plaster of Paris for 3 to 4 weeks. Main principle of this operation is suture two edges of nerve in the short distance. This may lead to restoration of nervous function and accelerating myelin production. Next is early postponed sutures. Method used after 3 to 4 weeks if primary suture is not done. Secondary suture performed from 4 to 6 months up to few years. Cicatricial tissue, which is called a scar, dissected around nerve and edge are sutured. Large dissection and then healthy nerve is displaced to injured nerve. Edge of damaged nerve is sutured. In some cases, transplantation of nerve is done. Next is neurolysis. Separation of the nerve from the cicatricial tissue. Patient lies on a back or abdomen. Skin dissection 8 to 10 cm from the projection of the nerve, fascia and cicatricial tissue separated with blunt hook to penetrate the intermuscular spaces. Upper and lower part of the damaged nerve is separated and held with plastic handle. Then cicatricial tissue is dissected on nerve and separated. Nerve is lifted with plastic handle and then checked by conduction with sterile electrode. In case presence of conduction, nerve is whipped with moist gauze and cicatricial tissue is removed completely. In case of conduction is absent, then neuroraphia is done on distal part of the injured nerve. Then the catgut suture is done. Next is suture of the tendon. Operation on tendon is tenotomia, tenoplastica and tenoraphia. Indication trauma. Depending on the timing, primary, secondary, early, secondary, late. Primary from 6 to 24 hours after trauma. Secondary early is 2 to 3 weeks after trauma. And secondary late is after wound healing. First is tendon suture on a synovial sheath. During primary treatment, tendon is held by forceps and dissected until it reaches normal suture of the tendon. Proximal part of the tendon is connected with muscular end. Tendon is found and edge of the wound is dissected longitudinally. End of the tendon is retracted and lateral suture is performed to connect both ends of the tendons. Another method is thick silk suture 1 cm from the cut edge. Tendon suture on the synovial sheath. The tendon suture on the synovial sheath are by Lange, by Cuneo, by Bolka and Bone, and by Kazakov. Types of tendon suture are Dreyer suture, Hicolando suture, Masne suture, Rotter suture, Rosavo suture, and Williams suture. Next is ligation of artery by length. Distal part if it is bleeding, proximal part and main branch is ligated. For example, hand is bleeding, brachial artery is ligated. Concept of collateral blood supply. Arteries which has collateral branch is ligated to enable the blood supply to distal part. For example, elbow region. Ligature of the artery is performed distal to its branch. Blood supply is perfused by collateral anastomosis. Concept of reduced blood supply. Artery is ligated and tissue is devoid of blood supply. Then veins carry extracellular fluid away from the tissue, thus causes damage to the tissue. To prevent this, artery and one of the two veins have to be ligated together. Okay, now till here were all the operations which were remaining of the upper extremity. So here we end our topic of upper limb. So next topic would be lower limb. Hope so you like my videos, you learn something from this. If there is any confusion, please let me know. I would correct it, I would improve it. You also keep learning, keep watching. Thank you. Bye bye.